Morning, everyone. Sorry you can't see me over this screen, but that's the way it goes. So welcome to this lecture by Dr. Connie Guille. I'm Judy Regensteiner. I'm professor of medicine and director of the Center for Women's Health Research. Our mission is to do the cutting-edge research of women's health and sex differences in the areas of cardiovascular disease, diabetes, and mental health, to educate and mentor the next generation of scientists, MD and PhD scientists, men and women, who will do the work in women's health and sex differences, and some of whom the center scientists are here today, which is great, and to educate the public and healthcare providers. So we are delighted today to have a visiting professor, Dr. Connie Guille, who I can't even see over the screen, but she's there. And thank you so much for coming. Dr. Guille is Associate Professor of Psychiatry at the Medical University of South Carolina. Her focus is on prenatal addiction, which is really a frightening phrase, even thinking about it, and that's what she studies. There's a deep concern in her area, in her research, for both the mother and the child in this work. And so it's very important work and just really a pioneering field, I would say. Her clinical work focuses on perinatal psychiatry as well, so her research and her clinical work are of a piece, and such an important area. And I want to welcome her today to give the talk, Improving Treatment for Pregnant Women with Opioid Misuse and Opioid Use Disorders. I was told by my daughter, who has done some research in addiction, that you never use the word addict. And I see that that is not happening here. But again, thank you all for coming. For those who don't know, there's coffee. There are coffee and snacks in the back, and I want to thank the center staff for their hard work in putting together the visit that we have with Dr. Guille, and I really want to thank Dr. Guille again for making the trip to Colorado, where we had such beautiful weather. We tell people it's sunny most of the time. Yesterday, not so much. Thank you.
Can you hear me okay with this mic? Great. Thank you so much, Dr. Regensteiner, for the really nice introduction. And it has been such a pleasure to be here over the past couple of days. I've just had a number of really wonderful meetings with some really talented faculty members and some really exciting discussions just about the work that people are doing here and potential for collaborations. And I'll share a funny story. I was telling my daughter this morning just a little bit about what I'm doing here and kind of what's happening and how excited I was. And she was like, oh, so it's kind of like Disney World for adults? And I was like, yeah. I was like, that's actually a pretty good analogy. It's an academic Disney World. So thank you for all that. And thank you to all the staff that have helped kind of coordinate my day and make this run so nicely. So I'm going to talk about the treatment of opioid use disorder and actually opioid misuse in pregnant women. I have a clicker here, I think. Are you hearing okay? I can use the mic if you want me to. You want me to do the mic instead? Okay. Great. Is that a little bit better? All right, good. Thanks. So what I wanted to do before I jump into pregnancy is actually just talk a little bit about opioid use and opioid use in our country and how that's impacting women's health, some of the really important sex and gender differences that we are seeing in this area, and then I'll focus in on the pregnant kind of postpartum area. And I think about pregnancy and postpartum as, this is really a snapshot in just some women's lifetime. This is really a very, very small point in time when you think about kind of the lifespan of a woman and what her health looks like over time. But the reason why we focus here has a lot to do with the fact that these women are always excluded from every single research study. If you think about your first exclusion criteria that you put down for your research study, it's pregnant women. So we know very little about this population. And I understand kind of wanting to be very careful around how we include these women in research, but when we don't, we do a pretty significant disservice to how we actually treat them. The other reason is that it's really interesting to watch women who become pregnant and they will change so many health behaviors. They're really motivated towards positive health habits, and so we can kind of capitalize on that in this work. They also have health insurance, and they're coming in for regular visits, so it's just this amazing window of opportunity to treat addiction and other problems and really set people on a different trajectory. So that's kind of why we focus in this area. So I don't have any conflicts of interest. These are some of my funding sources. And instead of doing kind of like a deep dive into any one of these projects, what I thought I would do is kind of an overview and then more of a breadth of what I've been working on. And if there's anything that you're more interested in, we'll go in a little bit deeper. So just some background and context. So in the United States, we as Americans, we consume more prescription opioid medications in comparison to any other developed country. And as you could imagine, if we have a lot of people using these medications and they have an addictive potential, it's not so surprising that prescription opioids are now the second most common substance of abuse in our country. People have probably heard a lot about the national emergency, or formerly the opioid epidemic, with just rising numbers of deaths due to opioid medications and other opioids. We have about 10 million people in our country that misuse opioids, and what that means is that they're just using these drugs outside of prescribing parameters. So that could mean they're using it to treat their sleep problems, or maybe mood problems or anxiety. It could mean that they are not taking the medication in terms of the dose and frequency that's prescribed. It could mean that they're taking it from other people. And the reason why that's important is that is one of the strongest risk factors for developing a substance use disorder or having an overdose and potentially death. So there's about 2 million people in our country that have an actual opioid use disorder. And again, just kind of highlighting some of the things that I think are kind of important in tracking these waves of opioid overdose deaths and understanding where we've been and kind of where we're going. We really started out with the epidemic in about 1999, where we have essentially a 16-year, 17-year trend of increasing opioid overdose deaths as a result of our prescription opioids. So these are things like oxycodone, hydrocodone, kind of your semi-synthetic and natural opioids like codeine. And then around 2010, we saw this pretty significant uptick in heroin use. And we have subsequently learned that 4 out of 5 people that are initiating IV heroin use actually started their opioid use with a prescription opioid. So it's thought more to be a part of a gateway to heroin. The next kind of wave that we're seeing, 2013, we've really had a huge uptick in the number of people that are overdosing as a result of synthetic opioids. This has to do with a few reasons, but one is that these are incredibly potent medications, like 10,000 times more potent than morphine. So you just need a very little amount of this to actually overdose. In some places of the country, people think they're using heroin, but they're actually using fentanyl. Fentanyl has always been cut into heroin, but in some places it's like 100% of the heroin. So really common to see that. In terms of opioid overdose deaths, men are much more likely to overdose in comparison to women, but there's been some really disturbing trends, I would say, in women's health where in the past, 16, 17 years or so, we have seen that the overdose deaths related to prescription opioids in women have increased by 471% versus 218% in men. Synthetic opioids increased 850% in women, and heroin about 100% in comparison to men, which is 50%. So there's maybe some important reasons for this. One is that women are much more likely to be diagnosed with a pain condition, even acute and chronic pain, in comparison to men. They report having more pain and more pain severity. But actually, when you look at a pain population, so people that have non-cancer related pain, women are still more likely to be, in comparison to men, more likely to be prescribed an opioid at a higher dose and for a longer period of time in comparison to men, and less likely to be prescribed naloxone, so the antidote to an overdose of an opioid. Another important phenomenon that we know about in addiction in general is that women and men have a different sort of time course with their use of substances from start to when they develop problems. So women have a much shorter period of time from first starting to use a substance to developing problems psychologically, physiologically, and also less time to get into treatment. When we look at overall a population of people that have a substance use disorder and those that have opioid use disorder, they are much more likely in comparison to men to have a comorbid psychiatric illness. They have a lot more trauma, more functional impairment. They use substances oftentimes in response to mood and stress, which is different than men. One of our studies right now is looking at gender differences in men and women around stress-induced relapse and using some medications that block the noradrenergic system system to see if it benefits both men and women in reducing relapse, but particularly we think it might be more helpful for women. One of the interesting things is that in the opioid world, women are much more likely to receive their opioid medications from friends and family, which is very, very different. And you could imagine if you're kind of on that friends and family plan, it is really convenient to get your substance, and it's also very normative. So people kind of continue to use a little bit longer than what you would normally think. So in terms of treatment, women are less likely to get treatment in comparison to men. There's some really important gender-specific barriers to treatment for women that need to be addressed in getting women to treatment, but also within the context of treatment, there are really some gender-specific issues that we need to be addressing for this population. So switching over into women of reproductive age. So these are data from about 4 years ago that showed that almost 30% of those that were privately insured, almost 40% of those that were insured by Medicaid were prescribed, actually they filled at least one opioid medication per year from 2008 to 2012. So that's just a huge number of people, and whatever is happening in women's health and in women of reproductive age is just going to be reflected in pregnancy. So it really shouldn't surprise us too much that roughly 15 to 20% of women are prescribed an opioid during pregnancy. Those that kind of have more chronic use of opioids, so they prescribe, they take their medication consecutively, so 2 or more consecutive prescriptions for a medication. It's a smaller group, but it's an increasingly common group. So where I sit in terms of my clinical work, we integrate mental health and substance use treatment into OBGYN practices. And about 5 years ago or so, the OBGYNs and I were kind of looking at this population when all of a sudden we're seeing more and more opioid use, whereas before it was depression, anxiety, trauma, and now we're having to figure out, well, wait a minute, there's opioids here, how do we handle this? And so it was this mix of people that they had some sort of chronic pain condition. Their primary care doc had been prescribing them opioids forever. They become pregnant, and the primary care doc says, you're no longer my patient. You got to go see the OBGYN. They go to the OBGYN, and they're like, I know nothing about pain or substance use or opioid misuse. So it was really kind of a group effort to try to figure out what to do here. So the first thing I always do is go to the literature, and this is my analogy to a gap in the literature. There was literally nothing about how do we best treat pain in pregnancy, how do we handle opioid use and misuse, and if it's important for someone to come off, how do we actually do that? So there was just a kind of a wide open area of research. So, of course, the first thing that we do is we go to the general literature. So hopefully women, we can get some information about non-pregnant women on how to treat chronic pain. We try to adapt that for this population. And when we're trying to make medication decisions in pregnant women, we kind of have these, what we consider risk discussions. And so we're thinking about, well, what's the risk of this person's untreated illness, and what's the risks of them actually having treatment for this and any potential benefit from the treatment? And so what we would see is that these were women that were, say, on oxycodone, 120 milligrams a day, and they were coming in saying, I still have a pain rating of 9 out of 10. And so in my opinion, that means that that treatment's not really working for you. And it doesn't make sense if you're not getting benefit from this drug. Why are we taking all of these risks, especially if you're misusing this medication, putting you at risk for a whole host of bad outcomes? But while it made sense to maybe take them off, I didn't know what to do about their pain, and we needed to figure that out. And we also needed to figure out how to actually taper these meds and keep a close eye on pain. And one of my biggest concerns in doing this study was potentially fueling drug-seeking behavior as I take the opioid away. So we designed a study looking at cognitive behavioral therapy for chronic pain. There's a good evidence base for this sort of psychological intervention in non-pregnant populations, and we paired that with kind of a medication management style using shared decision making, really with the goal that hopefully with this sort of treatment we can improve maternal pain, we can reduce their opioid use, their misuse, and potentially reduce NAS or neonatal abstinence syndrome. So just really briefly, our study design, so we enrolled women that were less than 31 weeks gestation. They had to have daily use of an opioid, and they had to be misusing that medication, and they just needed to consider possibly coming down on that med. We excluded those with substance use disorders, and we collected a whole bunch of baseline information on this population, just in terms of their pain history, their opioid use, their current misuse of that medication as well. The treatment was developed for the CBT for chronic pain. I should say that the actual evidence-based therapy is 11-week session, which I just thought was a bit much. But we piloted that first in five women just to see what their thoughts were. Got feedback from them, kind of reworked the intervention a little bit, and then repiloted it in another 5 people. And so who I'm talking about now are the people that got the adapted intervention. So it was a 6-week intervention it was an 8-week intervention around the therapy. It was a little bit longer, around 10 weeks for the medication. And so weekly assessing OB outcomes and as well as their pain and their opioid misuse. So they delivered, and we followed up with them at 6 to 8 weeks postpartum. So in the study, on average, people were 30 years old. I'm just going to kind of highlight some important demographics. On average, these women had been taking these medications for about 6 years. So just thinking about the age of onset for a chronic pain condition to be prescribed an opioid, it's a little bit hard to wrap your head around. Primarily, this population was Caucasian. 77% had a low back pain issue, which opioids are not actually the treatment for low back pain. So a lot of them were not appropriately on the right medication. And 86% of them had a history of a mood or anxiety problem, which I think is a big driver in this area. So really quickly, just looking at some pre-post data, we see a slight reduction in average pain, their worst pain over a 24-hour period, and the impact of their pain on their functioning. And if you look closely at the numbers, it's really like 1 or 1.5 points improvement on these scales, which clinically is not very exciting. But when I think about this, we have women that they're pregnant, they're going along in pregnancy where they often experience more pain, and we're tapering their opioids. So I was just excited that their pain didn't get worse. So for me, like clinically, this is kind of a win, even though it's not a very dramatic reduction. This is just looking at pain scores on the brief pain inventory over time. And so as you can see, just basically we have a slightly downward trend to improvement, but not a whole lot. So this is our morphine equivalent dose. So everyone was on kind of a different preparation of opioids, mainly oxycodone, but you just convert it to a morphine equivalent so we can look at the dose over time. And as you can see, we were successful in getting women were successful in coming off of these medications. So about 80% actually completed their taper. The folks that stayed on were at very, very low doses. I'm not sure if that was even, I think they were kind of psychologically attached to the medication at that point. So one of our main outcomes looking at current opioid misuse, we do see a significant reduction in that, and I think that has a lot to do with just making sure people understand how these medications should be used, how they should be prescribed and not be prescribed. And we saw some benefit in mood and anxiety as well. This is just current opioid misuse measure over time. So the limitations really here, this is a pretty small sample. This is an open label study. We don't have any control groups, so that's kind of our next step in this area. And we also want to follow up these people much longer than just 6 to 8 weeks. It'd be interesting to see where they are in a year out. But in summary, we do feel like that we have some potential benefit in this pilot just using CBT for chronic pain and med management to reduce opioid misuse, reduce the overall opioid dose, and their pain is not getting worse. So that's great. I should actually put this on the limitations, but this is a pretty labor-intensive sort of treatment, and it's not always very accessible to people to come in for an hour and a half for treatment, and actually do a lot of work outside the session as well. So just in thinking about next steps, we have to figure out how we can design this so it is more accessible to people. The other thing I didn't mention was that in screening people for this study, one of the largest exclusions was that they had opioid use disorder. And so that's what I'm going to talk about next. So here are some of our national data looking at opioid use disorder over time and the diagnosis of this at the time of delivery. And essentially what we see here is essentially a 4-fold increase in the diagnosis of opioid use disorder over the past 15 years. Currently, it's about 6.5 per 1,000 deliveries in our country. So this is not an easy slide to read, but it is by far one of the best studies that has looked at some of the morbidity and mortality associated with having opioid use disorder in pregnancy. And so this was a data set of 57 million women. They controlled for a whole host of really important, potentially confounding variables. And even with that, they saw that women that had opioid use disorder at the time of delivery, in comparison to women without opioid use disorder, were 4.5 times likely to die at the time of delivery, 3.5 times more likely to have a cardiac arrest, over 2 times more likely to have intrauterine growth restriction, placental abruption, et cetera, preterm birth, just a lot of morbidity and mortality associated just with this disease. So the outcome that people hear a lot about probably is neonatal abstinence syndrome or newborn opioid withdrawal. Not surprising, if women are using opioids in pregnancy, we're going to see it in an uptick in this outcome as well. The average in 2014 was about 8 per 1,000 deliveries, which means that there are probably more women that are using opioids in pregnancy than we're actually identifying. You can see there's a big difference whether you are insured by Medicaid or you're insured privately. I think that difference has a lot to do with how we screen and who we screen for substance use disorders in pregnancy. I had to throw this study in here. It just came out. It's one of my favorite studies where they were essentially looking at just the association over 500 counties of NAS with a number of different social determinants of health and just important kind of corollaries of NAS and opioid use. And so overall prevalence of NAS was 7 per 1,000 births, but when you get into areas where there's mental health shortage, it's 14 per 1,000. And if you look at areas that have the highest 10-year unemployment rate, it's 20 per 1,000. So it just really highlights, this issue that we're talking about. This isn't just about newborn withdrawal. It's not just about women using opioids in pregnancy. There are really important economic, kind of health access and mental health issues that kind of encompass this work. So in terms of the treatment of opioid use disorder, really we want to focus in on the mother-infant dyad. We want to provide mom and baby with therapy, psychotherapy, and pharmacotherapy. That's for mom. We typically, the substances we're using in our program are buprenorphine, but methadone is another potential option. We're making sure that we're identifying and addressing mental health problems, trauma, looking at social determinants of health, and packaging that within prenatal care. So kind of one place where you can get all of these things. And we've seen in those models that there's better retention and treatment, we have better outcomes for mom and baby, and it's more cost effective. So I'm just going to take a second to pull out just one component of that treatment, which is the pharmacotherapy of opioid use disorder. A number of our professional organizations, including World Health Organization, CDC, recommend that if you are pregnant and you have opioid use disorder, the standard of care is that you are either on methadone or buprenorphine, and even now increasingly combination product with the buprenorphine naloxone. And so, that made a lot of sense when you think about from what we had known about prior to the prescription opioid epidemic, where people were really primarily using heroin. And what that data told us is that if women were not on these medications in pregnancy or they tapered off of them, they were at really high risk for relapse. Like 60 to 70% of them would relapse to substance use. And if you think about all the things that happen as a result of relapse to substance use, so IV injection of a drug, rapid cycles of intoxication and withdrawal. We have lots of risky behaviors, putting women in harm's way. We have legal problems that, in the end of the day, we're going to take the risks of methadone and buprenorphine, because if we don't, someone's likely to relapse and the consequences are really severe. So that's kind of what's guided this field in doing this. One of the things I was really interested in thinking about and learning about was kind of diving into that literature prior to the prescription opioid epidemic and currently to look at those risks of relapse in women. And so I did a little review in 2017. My colleagues did one in 2018. And what we actually know about women who are tapering off of these medications in pregnancy, their risk of relapse is somewhere between 0 and 100% or 14 and 74%. So we really, really don't know. And so there is a lot of work to be done to understand who is the best candidate for this, and who does this make sense to do this with, and who should we not be or recommending not doing this with. So, it's really hard to counsel women on and recommending a drug in pregnancy that potentially has their baby going through withdrawal when I tell them, your risk of relapse is, I have no idea, right? So one thing that I created and did some just pilot work on, some preliminary work with a cohort of women, was creating a shared decision-making tool. Are people familiar with these sort of things? So it's essentially a tool that helps facilitate the process of helping patients understand what are the risks of treatments, what are the risks of not being on treatments, and then individualizing things. What are the risks for you? So what's your risk of relapse? And let's list out those things. What are your protective factors? And what are your values and preferences? What do you want here? And so when you can consider all of those variables, what our paper here showed was that 95% of women will make a decision in that session right there, which is amazing because typically people like to punt this decision and then all of a sudden you're at 36 weeks and we just lost our window. People also really felt like they understood the risks, that they got good guidance, they understood kind of the medical risks, and that we were supporting their preferences and values. So just a little blurb on that. But so getting back to just treatment of opioid use disorder in general, and I kind of painted that picture of that ideal model that we would ultimately have. We know that this model does not exist in most places. I mean, there really are just a dearth of programs that have that sort of integrated substance use disorder treatment. But University of Colorado is actually one of them, so you guys should be very proud of that. It's great. And I see some folks in the back that are doing that work, which is really awesome. So one of the issues is that when you even get out to more rural places, you see even more of a disparity, and you actually have more maternal opioid use and more NAS. So we wanted to see if we could take our program, being in South Carolina is a very rural state, and see if we could deliver that program via telemedicine to other OB practices in our state. And if anyone ever wants to talk about actually doing this, I'm happy to go through the logistics and actually navigating some of the federal and state issues that need to be navigated there. So we did a non-randomized control trial with a group of women that were either getting their care with us in person, in that in-person integrated model, versus telemedicine. We wrote a standardized protocol for this work, and it was all the same providers that were delivering it, so that was pretty great to get everyone easy to get everyone on the same page. We then, our main outcomes here, our main one was a maternal outcome looking at retention and treatment. We defined that as continuous addiction treatment, including uninterrupted pharmacotherapy, at least monthly visits with a prescribing psychiatrist during pregnancy to 6 to 8 weeks postpartum. And then we were also looking at newborn NAS. So, ideally we would have done a randomized control trial here. Kind of the next best step is to use propensity score weighting. It's just a way that you can help to reduce the selection bias for the groups of folks. We also then obviously did a regression with covariates that we think were important in impacting our outcome. So our statistician calls this a doubly robust estimation. So you're kind of using this two-step process. So in terms of our overall participation, we used 3 telemedicine sites and 1 in-person site. There were 44 women in telemedicine that came to see us, and then 3 of them actually said, you know what, I'm not going to continue here, I have a provider. And we said, great. And similarly, in the in-person practice, we saw 54 women, evaluated them, and about 6 of them said, I'm good, I don't need to continue in the program. So those are our ends. This is just basic demographics comparing these 2 groups using our statistical approach of trying to balance groups. And the only difference that we had here is the telemedicine group was more likely to be married or engaged than our in-person group. Comparing them, these 2 groups across a whole host of characteristics that are important in terms of opioid use, how long you've used, what's the severity of your use, what's your treatment history. We had really good balance between those 2 groups. Looking again, history of our current substance use disorder or any sort of psychiatric issue. Again, no differences between groups except for our in-person people. When they came into treatment, were more likely to be prescribed benzodiazepine in comparison to our telemedicine group. So our main outcomes, really, we basically saw that there was no difference, no statistically significant difference between groups in terms of retention and treatment or newborn opioid withdrawal. These are just our secondary outcomes, looking at urine drug screen between two groups. Again, no major differences here, and also no difference in the duration of newborn hospital stay. I will say, however, the prevalence of people having positive urine drug screens in this group is pretty high. They're getting what we think hopefully is the standard of care and getting what they need, but we still are having people use substances. And that just tells me we need to have a lot more work to do in this area. It also tells me that this is a group of people that have pretty severe disease. We think about pregnancy as almost like a first-line intervention for substance use disorder, where women will get pregnant, they'll just stop using their substances. It's not a recommended intervention in whatsoever, but what happens is then the people that are left are the people that are really, really struggling. Like, they have a very hard time stopping their use. And then if you've then decided, I'm going to take a medication such as methadone or buprenorphine, you're even a more severe group. So that's kind of who we're working with here. So as I mentioned, this was a non-randomized controlled trial. I really think we will be following these women up 12 months postpartum. We're not there yet. This is in one state, and our newborn assessments were just EHR, so not ideal. So I do, however, think that using telemedicine to provide this delivery of care is one potential option. It's a very good scalable option, and we just need to continue to do some more research in this area to see if this is good for a larger group of people. So I just wanted to take a second to talk about where we are and where we're going with some of our telehealth work, which is home-based visits. I think that makes a lot of sense, particularly for this population. The other area that I really like is trying to create a virtual collaborative care model where when the patient is in the OBGYN practice, they're identifying any particular issue, they can just get tele right away. So just immediate access to telemedicine as opposed to scheduling and that sort of thing. So we're looking at on-demand telehealth and pairing that with home video visits as well. I'll take a second to talk about an R34 that I have, which I thought I had this good idea to take what it is that we're doing in in-person practice, see how much of it that we could make web-based for patients and providers in managing opioid use in pregnancy. And we kind of mocked up the storyboards for that. We sat down with providers and patients separately. We did key informant interviews and focus groups and really got people's feedback about that sort of setup. And it was not very positive. It wasn't totally negative, but it was, the providers were saying, yeah, that sounds like a really good idea, but I think it's really for the OBGYNs that are buprenorphine waivered and willing to do this, right? But we talked to those docs too, and they said, oh, this is really good for the generalists. So I think they were being nice and just saying, we're not going to use this. The women that we worked with, they said, yeah, that sounds good, and maybe I'll use it, but like the number one most important thing about my care and my care with it throughout this process has been the connection with the team and the whole group of people that I'm working with. So we kind of had to shift gears a little bit and rethink this, and what we actually came up with, and actually one of the other kind of important components and why we went in this direction just had to do with basic screening. So the OBGYNs didn't feel like they were adequately screening or screening appropriately, and the women would say, in my prior pregnancy, I flew under the radar, no one even knew that I was, so there was a detection issue on both sides. So we thought, well, what if we took our screening tools that we have and we make them kind of text-based? There's some interesting data in the substance use area that people are more likely to endorse substance use if it's more confidential as opposed to an in-person interview. So we thought maybe putting it on people's mobile phone, that might be a better way to detect. That data from the screening, it leads to a little bit other screening and pulls some data from our EHR. That kind of goes through an algorithm that puts those people into a risk category. So they could be high-risk substance, low-risk substance, they could be at risk for depression, they could have depression or domestic violence. So the care coordinator then is looking at that data and calling the patient, or if they're in the office right there and then, they can see them, but just doing more full assessment, really figuring out what's going on, and doing that kind of motivational interviewing to help that woman take the next step to treatment if that actually made sense. And then all of that information getting coordinated back into to the providers, and we can do some of that through the EHR. So that's where we're going right now. We just finished creating our technology. We've tested it. It seems to be going well. And now the next step is to actually do an RCT pilot just to work out some of the methods with that. So that's where we are with that. And yeah, that's really it. I just wanted to acknowledge I work with a fabulous group of people in South Carolina and really great mentorship and collaborators. I just want to acknowledge the women that take part in our studies and work with us. They're pretty tremendous, and obviously our funding organization as well. So with there, I will stop and take any questions.
We have time for questions.
Thank you so much for a really fascinating talk. My question was, it looked like across your studies you showed the data from that the average age of study initiation was around 19 weeks gestational age.
Yes.
In terms of trying to prolong these procedures for both maternal better outcomes, but also for those early time points that are so important for fetal growth and brain development.
Yeah.
Thinking of neonatal outcomes for the babies, is there any way to kind of start these studies earlier?
I would absolutely love to do that. And yeah, so on average, 19 weeks gestation is where we're seeing these women. And a lot of that has to do with the fact that they're not showing up to care until really late. So they come to care maybe around like 17 weeks, and it's a little bit of a delay to getting to us, because even if we're in the office, they're saying, yeah, I'll come back for that. They're there for their first prenatal care visit, which is like 4 hours, and then they don't want to deal with this on top of it. So there is a delay. There's a huge delay. I mean, we've missed half of their pregnancy, so we need to be doing a much better job in that area.
I have a quick question.
Yeah.
What about the role of stigma? This has got to be double, triple,
Yeah.
quadruple stigma to
Yes.
be a pregnant woman who's been choosing drugs. So
Yeah.
how does that work? Do you feel like you're...
Yeah. Yeah. Oh, yeah. No, I mean, that's a huge issue in mental health and substance use. We're always fighting against that. But, also if you're a woman and you're pregnant, we are super judgmental of women and pregnancy and parents in general. So this population really, they are shamed all the time by our healthcare providers. They're judged. It's really hard for them to ask for treatment. It's hard for them to stay in treatment because they feel that everywhere they go. So anyway, we need a lot to do more work around that area.
Does it affect attrition though?
I've never seen a study that actually measured stigma and attrition. Maybe I'm missing that, but there could be something. I don't actually know. But yeah, I think when people get into a group that's non-judgmental and less stigmatizing, they tend to stay with them. But that's just clinical experience. Yes.
I have two questions. Well, I have a lot of questions. Thank you so much for this important presentation. In a study with the 20% urine positive toxicologies, was that including cannabis, all substances, or was that solely opiates, or what was the composition of those toxicologies?
So including everything, so just positive urine drug screen that happened. The vast majority was opioids. The second was cannabis.
Okay.
Yeah.
And then my second question, maybe asking for more. One of our biggest struggles in Colorado and nationally, right, is postpartum relapse.
Yes.
And how
Yeah.
that fits in locally for us, how that shows up is in significant maternal mortality.
Yep.
What recommendations, best practices would you suggest for helping retain women in treatment postpartum? And if you see a role for partnership or how to work best with child protective services for those families?
Yeah, that is a great question, and it's a huge issue, and there's multiple layers in which we need to be intervening. And the first is just extending Medicaid for at least the 12 months postpartum. So in our state currently, which is now changing, was that women who have Medicaid, their health insurance, it lapses 3 months postpartum, right? So all the treatment that you were getting, if you were getting evidence-based treatment, it's now gone. So I think that actually probably has a lot to do with then the relapse and overdose death rates. So first level is making sure people have care and access to care. I work in a state where our Department of Social Services is not viewed positively in any way, but they have some positive interventions. And so I think for them, the reason why that there is that perception of them is that there's so much inconsistency and variability in how social services intervene. So we need to kind of standardize that, and we need to have a lot of non-judgmental people working in that area that understand addiction as a disease and that we need to be treating it appropriately. So kind of system levels, interventions. I mean, I wish that I could just take every one of these women home for me for the next year. You know, it's like I just want to keep them in my, like, right next door. And I really would love to think about how to actually create that, because these women are really isolated, and because of the stigma, but there's so many other women that are just like them. And so creating more kind of gender-specific treatments where you have a group around you, you have a group of peers, because it's social supports, right, during that time that really helps prevent relapse, and it helps people not get depressed and that sort of thing. So somehow creating more social supports and helping actually women to figure out how to get social supports. Like, it's helping them actually navigate those relationships and why they're important, and that's kind of part of the therapy and treatment I think that we need to be doing. So it's kind of a long-winded answer, sorry. Yeah.
On the question of stigma and bias, you spoke to methadone and buprenorphine, and historically there has been some bias in terms of which patients are offered methadone, which involves going to a clinic publicly, admitting that you have an opiate problem sometimes, versus being prescribed buprenorphine, which you may take at home. Have you found effective ways to increase buprenorphine prescribing in this population? Because I would think that would be very effective versus forcing them to go wait line for methadone.
Yeah, absolutely, and it's important for a number of reasons. On that, also, when we compare the newborn outcomes with buprenorphine versus methadone, they're actually more favorable with buprenorphine, and so there's a number of reasons why buprenorphine makes a lot of sense. So, in terms of gosh, I just totally lost my train of thought, sorry. So in trying to get more women kind of on these medications, one of the important things is to look at your state infrastructure. So for us, we have all of these for-profit methadone treatment centers that have really done a masterful job of running the market and getting pregnant. Like, so if you're a pregnant woman in the state of South Carolina, you would say, oh, I go to a methadone treatment center for treatment. And they are welcomed with open arms because they get money for treating these women. So that's kind of one layer that we really need to work on, and really actually educating the methadone treatment centers and other people about some of the advantages of buprenorphine and how it can be better for some, and certainly OBGYN providers. So there needs to be kind of a lot of education about that. I would love for more OBGYN providers to actually be able to prescribe buprenorphine, so actually going through the training, so if you're in the door, you can just get started. But I think, yeah, there's layers of things that we need to be addressing, but it's a really good point. Yeah.
What's the gender trends rate in terms to the C-section related pain management in South Carolina? What's the gender trends? And I ask this because Colorado here, this campus already had publications linking electronic health records with claims data to follow up with.
Yeah. One thing that I'll say about prescribing prescription opioids in the postpartum period, it is so variable. But there are a lot of institutions that are really working on curbing some of that and doing better monitoring of how much they're prescribing and making sure that people aren't continuing these medications. There was a question in the back.
Yeah, thank you for a wonderful presentation. Sorry, I arrived a little late, so you may have covered it. I had a question about the study design for the non-RCT, because it seems like, and there's probably a very good reason for it, it seems like you went non-RCT and then used propensity score to sort of re-randomize, so to speak, for confounding. Can you speak a little bit to that approach?
Sure. So that had to do with resources. So that work started, I had my K where I was doing that chronic pain study, and all these women were screening out because of opioid use disorder, and I was getting some funding to do tele. And so I was like, all right, well, let's actually do a sub-study. And I didn't have the resources to really do it, so I kind of piecemealed it together, but it worked out okay. So yeah, not ideal. Good question.
No, that makes sense. Thank you.
Yeah.
Thank you all very much. That was just terrific.
Thank you for all the questions. Thanks for your questions.